So today is the fourth of seven session of the Learning Webinar series with One NHS Finance. And we have an amazing speaker today, James Ransom, who I believe is an expert of clinical coding, and he'll be providing insight into the role of clinical coding in service payment, as well as address. If it's helpful, can we just mute ourselves, if that's all right? Okay, thank you very much. So yeah, James will be providing insight into the role of clinical coding in service payment, particularly around how it affects operational managers. So looking forward to it. Next slide, please. Thank you. So if you see me for the first time, I'm Esther, and I work as a program manager with Horizons. Horizons is the umbrella team for Proud2bOps. And if you are active on any social media platform, particularly X or LinkedIn, please to give Proud2bOps a follow, and you can follow me on there. On social media platforms, we share information around Proud2bOps and the events and sessions that we have coming up. So it might just be want you to give us a follow. And if you share insights from today, please do give us a tag. We would really appreciate that. Next slide. Next slide, please. Thank you. Okay, so we're conscious that, yeah, every week, every day we have new people join our network, and we believe that in a space like this, it is important for us to sort of emphasize our throughout the session today. So we like the space to be a safe space. We want you to be curious so that we can generate ideas that you can use to lead improvement within your organization. We also wanted to have fun, so please do use the chat box to leave your comments, to leave your questions, and do like any comments that you know relates to you. It would be nice for us to have fun and also engage within the space today. So next slide, please. Thank you. So yeah, here is a few events that is coming up with Proud2bOps. Like I mentioned earlier, this is the fourth of seven sessions. And on the 25th of September, we're going to be having introduction to NHS procurement. So you might have people within your team and organization that would benefit from this session. So if you want to tag them and bring them along, that would be good. So on 14th of October is the sixth session, which will be looking at budgets and spreadsheets. And on the 29th is business case in healthcare. So what we try to do as Proud2bOps is to have sessions like this that answer to the needs that operational managers constantly speak about or come to us about. So on the 3rd of October would be a roundtable with one of our partners, Johnson & Johnson MedTech. So if you're a member of Proud2bOps, I'm sure that you would have received a calendar invite to this event. And the much awaited in-person meeting will happen on the 5th of November, and that is our annual Congress. And for the first time, this would include Proud2bOps awards. So we have different categories, I think about 6 categories that would like you to provide nominations to. So next slide, please, Alfie. Thank you. So to share your nominations, please do scan the QR code on your screen. There are different categories, and their whole idea is to celebrate operational excellence. So it'd be nice for you to put in your submission as well. Next slide, please. So at this point, it is my pleasure to hand over to James Ransom. Thank you.
Thank you very much, Esther.
You're welcome.
I will start sharing my screen. So first of all, I'd like to thank you for inviting me to talk at this event. It is always one of my priorities at the moment is to try and raise awareness about clinical coding. So I've done a lot of work at local schools and colleges and universities, just raising awareness of what clinical coding is. Certainly when I first came became a clinical coder, one of the most difficult questions to answer for me was, what is a clinical coder? Because it's really hard to kind of describe. So this is a session called A Welcome to Clinical Coding. My name is James Ransom. I am an ACC, so those are the letters that we get once we pass our clinical coding examination. And I am also TAP.cert qualified, so that means that I am certified by the Training Academy to deliver training sessions. It looks really nice on there, and once you're a qualified coder, you can then go into those sort of areas like training and auditing, and you get some nice letters after your name. So I am the only trainer at my trust. The trust I work for is East Suffolk North Essex Foundation Trust. There are two main sites. There's lots of satellite sites for ESNEFT, but the two main sites are Colchester and Ipswich Hospital. I'm based mostly at Ipswich, but I do deliver the training and are responsible for the training across both Ipswich and Colchester sites. So a little bit about me is I started in the hospital trust in 2002, working as a student in medical records. So I used to go to sixth form, and then in the evenings I came into work and I did lots of filing. The reason that's important is because many people ask what qualifications is needed to become a clinical coder. The answer is we don't really need any specific qualifications. We look for our GCSEs. So I used to say A to C, GCSE, at least 5, but it's not that anymore, that's numbers now. But other than that, there are no degrees or anything that we look for in order to become a clinical coder. So I started in 2002 as a student, then I moved to coding in 2010. Now I wasn't becoming a coder, I was a clerical worker searching for missing notes to give to the coders. So as I was doing that, I kind of sparked a little bit of an interest into what the coders actually do. And then I moved back to medical records really briefly to become a team leader. But as soon as a vacancy came up for a clinical coding post, I was all over it. So that is my history, personal history of clinical coding. So this session is going to go over these subjects. So first of all, we're going to talk about what clinical coding is and the two main classifications that we use in order to perform clinical coding. Then we're going to look at the clinical coding process, what the process looks like, and we're going to have a look at an actual coded episode, hospital episode. Then we're going to briefly go over the uses of coded data. I'll say briefly, there's a lot of finance people in here, I imagine, so you've probably got more of an insight as to what happens to that data than I have, but I'll go over the general use of coded data. And then we're going to look at the impact of words. Now, this is a really kind of important thing for coders. Obviously, we read everything, so all of the work that we put into the system are from words written from clinicians. So we're going to be looking at how the inclusion and omission of certain words impacts the trust greatly. Then we're going to be looking at the actual training program on what it's like to train to be a coder. Then we're going to talk really briefly about the examination. So the NCCQ examination, that's the National Clinical Coding Qualification Examination. Then we're going to have a little look at the audit program, and then there will be a chance for questions at the end. Before we begin, though, I do invite somebody to kind of speak up. I'd like to know if anybody knows anything about clinical coding already before we start the session. Do we have any, not experts, but anyone with any knowledge of clinical coding in the room at all? Andrea.
Hi, yeah, I'm actually a clinical coding auditor, an approved auditor. My service manager has asked me to come on just to see whether we thought it were appropriate for our ops people and that, just to give her a bit of feedback. She couldn't attend herself, so she wanted some feedback as to how she thought we'd be able to, whether it'd be relevant or not, if that's okay.
No, that's excellent. Actually, you might be able to help me with the last part when I talk about auditing, because I'm not an auditor myself. So I might dip into that knowledge when it gets to that section. Thank you, Andrea. Rachel.
Hiya. I've got a background in ops for dermatology, so I was looking at the coding for the department and how to kind of streamline that and just make it accessible for everyone. So that was a big piece of work that I was doing then, but I'm kind of looking at how I can develop it across 2 services now. So yeah, that's why I thought I'd just come on and get a bit more info.
No, that's superb. And actually, dermatology and plastic surgery, for my trust specifically, we've been having a lot of trouble with our dermatology and plastic surgery department because of documentation. They're not great with documentation overall at this trust anyway. So yes, thank you very much, Rachel. And Linda.
Thank you.
Hi, yeah, I'm a coding manager in the Northwest. So if you need any help, I'm here.
Excellent. Well, that's nice to know. I've got some support here in terms of like code and knowledge, because I'm going into this from a trainer's kind of perspective mostly. I'm a training manager, so I've kind of developed the training program here. I do know a bit about this. I've been a coder for the best part of 13 years. So thank you very much for all of that, people. Thank you. So are you ready for it? So first of all, we're going to talk about what clinical coding is. So the NHS England definition of clinical coding is it's the translation of medical terminology that describes a patient's complaint, problem, diagnosis, treatment, or other reason for seeking medical attention. So that is kind of the most simplified version of the definition that we have. Now we do this using 2 classifications. The classifications are ICD-10. So this is the classification that we use for diagnosis and conditions. So that's the green book there. And then we have the OPCS in England, which is for procedures and interventions. So these are the 2 books that we use. Currently, most trusts, I dare say, are still using physical copies. We are moving towards the electronic copies quite quickly, I dare say. So I've just been given a laptop, which is like a touchscreen laptop, which I'm going to be using as like a tablet when we have to use these electronic versions. So clinical coders are required to assign codes accurately and consistently in according to standards. So we have these 2 classifications, but we also have some kind of rule books that we have to adhere to. So those rule books are studied throughout the very first course, called the Clinical Coding Standards course, and that's how a coder embarks on the clinical coding role. Now these codes can be easily aggregated, tabulated, and kind of organized for statistical reasons. So that is what clinical coding is. So basically, a clinical coder reads through medical notes. We try to look for medical terminology, and then using our books, we then find the actual codes, and then we put them onto an encoder. So thank you to Future Focused Finance for allowing me to use this illustration here. So we code diagnosis and we code procedures using the 2 classifications that I just spoke about, ICD-10 and OPCS. And another important factor is comorbidities. Can anybody tell me what a comorbidity is? Anybody familiar with the term comorbidity? Olivia.
So I'm not a clinician. Hi, I'm service manager at Birmingham Children's Hospital. So my understanding of a comorbidity would be something that is you've already got a pre-existing condition. So for example, diabetes could be an example of one of those. So it may be relevant to the treatment that you're having, or it may not be relevant, but they're all kind of comorbidities. So yeah, anything pre-existing.
Perfect. Thank you very much, Olivia. That is perfect. And you said it's pre-existing, which is as normally the case. But comorbidities can kind of be developed during a hospital stay as well. So we would code the comorbidities in addition to diagnosis and in addition to procedures. And then those would all go into an encoder. and it will generate an HRG. Now, an HRG are like groupings of similar hospital stays or similar episodes, and they all have kind of similar payments. So any documented diagnosis is coding using the ICD-10. There are over 14,000 codes for ICD-10, and it's divided into chapters. So there are 22 chapters in ICD-10. So, for example, Chapter 9 is diseases of the circulatory system. Chapter 10, diseases of the respiratory system. And then procedures, we have the OPCS-4. There are 24 chapters in OPCS-4, each divided into body systems. So our software takes all of this information and then it generates this HRG code. Now, this is what a coded episode looks like. Now, the style that you see here is a screenshot from a software that we use at our trust called Medicode. So we put all of the codes onto Medicode, and then we press process, and then that gets automatically kind of populated into our EPR, which at the moment we use in Lorenzo. So this coded episode here, we have a patient with acute appendicitis, and we have 2 comorbidities. So we've got type 2 diabetes mellitus without complications, and we have our essential hypertension. And then we have our procedure code at the bottom there, which is emergency excision of abnormal appendix, NEC. Now, NEC means that this is kind of like an unspecified version of that code. And then at the bottom, we have our HRG code, FF37D. Now, as I expect, we're all familiar with HRG codes and what their uses are. We've got a price next to that, our tariff price. That's what the trust will be reimbursed for that episode. So for a person with acute appendicitis, 2 comorbidities, and an emergency excision of abnormal appendix, this will be an open procedure. We would get 2,846, at least that. That's the HRG group. Now, we know that's an open procedure code because there is no indication of it being endoscopic or minimal access. So the default for procedures is normally open. Now notice on that screenshot it says the first diagnosis is the primary code. So there's a number of things. HRG codes are a very complicated thing for people like me who don't know much about how an HRG is generated. But one of the main kind of drivers for an HRG code is the primary diagnosis. So the primary diagnosis must be entered in the first coding field. So here we know that the primary diagnosis is acute appendicitis. If the E11.9 was to be coded first, then the primary diagnosis for that episode would be diabetes, and we'd expect the care to be focused more on the diabetes than the appendicitis. And same with the procedures. If we've got more than one procedure, the main procedure would be coded in the first procedural field. Now, these are just some of the uses for coded data. So we have clinical governance. This includes clinical audit, risk analysis, and mortality data. As we're on that subject, mortality data is being looked at my trust. I'm not sure if it's the same for all other trusts, but at our trust, mortality data is being looked at quite a lot at the moment, and coded certain codes kind of change the mortality data. So we go by our HSMR score. So if, for example, we coded palliative care, that would then be an expected death, which would kind of make our mortality data more accurate. So it'd be an expected death rather than unexpected death. Quality improvement. So this is all about improving patient pathways, clinical research, and treatment effectiveness. So we can monitor how effective treatments are by coded data. So we'd assign our codes, and then we could see if that patient had to be readmitted further on down the line. Epidemiological studies. So this is health trends, etiology studies, and clinical indicators. Clinical coding is used for benchmarking as well, so we can see how we are performing alongside our peers, reducing variation, and kind of gives an idea of a model hospital. Commissioning, so it's involved in case mix planning, development of new services, and financial flows. As I said earlier, the national tariff income, the HRGs, all come from our coded data, and cost analysis as well. So as our job stems from everything documented by clinicians, you can imagine the kind of challenges that a coder may face. Now, I'm not going to spend lots of time sort of making digs at clinicians, because I have a lot of respect for clinicians, and we have a really good relationship with our clinicians at our trust, so there's no bad blood there. But wording makes a huge difference for trust kind of data, and also for income. So for example, if a clinician wrote hepatitis, we'd code K75.9, inflammatory liver disease unspecified. If they wrote acute hepatitis, that would then change. One word changes that code drastically, so that would be K72.0, acute and subacute hepatic failure. If they was to write alcoholic hepatitis, again, that's just one word. That's a completely different code. We've now got K70.1, alcoholic hepatitis. So it's vital that we get all of the information possible from our clinicians, because it makes a huge amount of difference, not just for finance reasons, because you'll see in a second that if you add words, it doesn't necessarily increase the income, but for data. If a freedom of information request came in and they needed to know how many patients were admitted with alcoholic hepatitis, well, it wouldn't be coded as alcoholic hepatitis unless it was specified as such. So if a clinician just wrote hepatitis, patient alcoholic, we as coders can't assume that that's an alcoholic hepatitis. So as I mentioned, it doesn't always increase the price. So hepatitis unspecified would draw an HRG costing 1,036. If it was they were to write acute hepatitis, now these are without procedures, then the price goes to 611. And then if it was alcoholic hepatitis, again, the HRG would be 611. So coded data is very delicate in that one word can change so much. Sometimes clinicians ask why certain conditions and procedures kind of generates a less income or a lower income than others, but unfortunately that's just the way that the encoder software and the HRGs is generated. So we're like, you can't blame me. Don't blame me. It's all about the Medicode. Now to continue with the impact of words and the finance side of things. So we've got this patient, they've got acute appendicitis, K35.8, other and unspecified. And we've got one procedure there, emergency excision of abnormal appendix. Now notice that the wording is abnormal appendix. You might be wondering why is that specific to an abnormal appendix. There are cases where patients come in and they've got severe abdo pain. So they open the patient up and they're like, well, the appendix looks normal, but while we're here, we might as well pull it out. So there is actually a code for emergency excision of normal appendix as well. So you might wonder why that's a funny title for that code. But yeah, so this patient's got appendicitis, acute appendicitis, and there is one procedure here, and it generates a price of £2,721. Now, if we were to add the comorbidity of obesity, it then goes to £3,096. So one code there has made that much difference. I'm not going to do the maths because I can't do the maths, but that's the difference that one code could make. We've just added obesity to that patient. Now, if we add one more code, which is a likely comorbidity, respiratory failure, again, that income is increased to £3,569. So that's the importance of comorbidities. It can, not always, but it can increase the income as well as give us more rich data. Now, there are diagnostic terms that we can and can't code. So we have to code definitive diagnosis. Now, certain terms which are considered definitive in the coding world are presumed, probable, treat as working diagnosis, and local to my trust impression. Now, impression isn't a definitive kind of term in all trusts. We've got a local policy which allows us to code impression as a definitive diagnosis. This has been signed off by our medical director as well. And terms that we cannot code are possible, likely, query, question mark, suspected, and differential diagnosis. Now, what this means is if a patient came in with a cough and then the consultant wrote down probable respiratory infection or probable pneumonia, we could code that patient as pneumonia. If the same patient came in with a cough and the consultant was to write likely pneumonia, we would have to code that as a cough, and a cough is a symptom code, which coders don't really like using symptom codes because we like to have definitive kind of diagnosis. So as you see, we see question marks all the time. Sometimes we see probable pneumonia question mark or probable question mark pneumonia, and that sends us all over the place. So we know that question mark all too well, unfortunately. But when I deliver a lot of presentations to our doctors' induction days and also to clinical meetings, and I do say, I'm not trying to get anything untrue out of you. If it is really a possible pneumonia or possible whatever it is, then do write possible. I'm not saying you can't write this, but if it is more than a possible, if it is probable, then make sure you write it so that we can code it as such. I just see in the chat, coders manually go through notes to extract the information. Yes, we go through everything. There is a common misconception that coders only use the discharge summaries to code information, but we use the discharge summaries for a clue as to what's about to come. Certainly this trust, I can't speak for every trust, but the trust that I work for, I look at the discharge summary first because it's like reading the back page of a book. Just gives you a little clue as to what you're about to code. And then as you go through all of the clinical notes, all of the nursing notes, all of the radiology reports, you'll get a more complete picture. You'll notice that the discharge summary probably leaves out half of that information. So yeah, coders do manually go through notes to extract all information. So as I said a little bit earlier, unspecified codes can generate higher income. Marie Walker has kindly told us the reason for that. Unspecified codes often result in higher income and therefore does not incentivize clinicians to be specific. No, that's a really good point, actually, which is why I don't like to talk too much about money when I'm asking the clinicians for specifics. Quite often they come back and say, well, which one gives us more money? I'm like, well, I don't know. I could know because I could put it through our system, but I don't want to kind of tip it left and right. I need to know an accurate diagnosis so that we can code accurately. So thank you for that comment, Marie. Another challenge for clinical coders is this, as you can see. Now, this is a real kind of extract from one of our notes. Reading handwriting is a pain. Certainly for there is a couple of clinicians at our trust where as soon as we see the name, we're like, oh no, this is going to be a challenge. So reading handwriting is a challenge. And this, as I said, this was an actual patient. Things are getting easier with the introduction of so many clinical systems. And also at my trust, we're embarking on a brand new EPR called EPIC, You may have heard of Epic. So this is going to be an electronic medical record, basically. So there's going to be a lot less writing for us to read. I do understand clinicians are very, very busy. And as I said earlier, I've got a lot of respect for clinicians. I've been treated by clinicians myself in the past, and I've got so much respect for them. But it can be a challenge for us coders sometimes. We do have a good relationship at our trust with the clinicians, so there are no bad blood there. But it can be a challenge. And if you want to know what that says, it says abdo pain. Amongst there, it says abdo pain, right upper quadrant vomiting, or RUQ, with vomiting. Patient's been unwell for 5 days. They reattended, not readmitted. Pain is much better, except loose stools. There is no blood. So that's what that says. And it takes a little while to kind of try to figure out what some of these consultants are saying. If so, all of the things are listed there. Abdo pain. Don't know if you can see my mouse cursor. Abdo pain, vomiting, right upper quadrant. All of these would be symptom codes. So we'd be looking for an actual diagnosis. If there's no actual diagnosis, for example, if there's no appendicitis or no bowel obstruction or something like that, then we would code all of the symptoms. If a diagnosis has been made, which explains these symptoms, for example, bowel obstruction, then we would code the actual diagnosis rather than the pain, the vomiting, and the loose stools. So yeah, as I said, this is going to be less of a problem for my trust after October 2025, because we're going to have a brand new EPR, so we can shake it off all of these problems. So I'm going to talk about training a little bit. So the main objective is to sit the National Clinical Coding Qualification Examination. That is always the goal. Whenever we employ trainee coders, we make it certain that they're clear that they're expected to sit this examination. I don't think it's compulsory at all trusts. I've only ever worked at the trust that I work at now, but at our trust we make it clear that we want them to become an accredited clinical coder. So the main objective, as I said, was to sit this NCCQ exam. When the trainee is introduced into the coding world, the first thing that I do is deliver a course called the Clinical Coding Standards course. Now this is a 21 to 25 day, can vary depending on how quickly we get through. So it's an up to 25 day course, and what we do is we go through each chapter in both of the books, and we study each of the rules and conventions and standards that a coder needs to adhere to in order to do the job. So that's up to 25 days. You can imagine sitting in a room for 25 days. I like to do mine face-to-face because I get a lot more kind of interaction face-to-face. It is available online though. You can do the clinical coding standards course remotely, which in the future is obviously what we're going to be doing, especially as we're going to be employing people from around the country. It's not going to be just local to our region anymore. So the National Clinical Coding Qualification Examination, I'll go through that in a moment actually. So to start the journey, we've got this course, which is up to 25 days, and its purpose is to introduce the trainees to the books, how to use the books, and how to adhere to each of the standards that we must adhere to. After the standards course, the ongoing training depends on what trust you're at. So there isn't a standardized training program that's given to us by NHS England like there is with the standards course. After the standards course, it all depends on the kind of training program that's implemented at your individual trust. So I'm not sure what all trusts are doing, but what I'm going to do is just briefly talk about the training program that I've developed at this trust. So it's a 12 to 18 month training plan that we have at ESNEFT. So we've got we've got 12 modules. So when a trainee coder has finished the standards course, they come into the office and they're given a mentor. Now their mentor will be a senior coder, somebody who's passed the examination and has all of the experience needed to kind of answer questions effectively. So in the afternoons, the trainee coder will code. Actually, I'll go over that in a second. So we've got this 12 to 18 month training plan. So I've divided our specialities into modules. So when they come in, when the trainees are introduced into the office, the first module that they'll code will be endoscopy coding. The theory behind that is that it's a little bit quicker to pick up than other specialties. I say that's the theory because more recently endoscopy coding has become a little bit more complex than it used to be. So we've got endoscopy coding, that'll be upper and lower GI coding, excluding ERCP because ERCP is a little bit trickier, and we've got bronchoscopies in there as well. So during this module, we've developed workbooks for each specialties for the trainee to study. Now the workbook has all of the relevant diagrams that the trainee will need to pass the examination. So for example, the endoscopy module will have the diagrams of the digestive systems. We've got the module 2, obstetrics, so that'll have the diagram of the female genital tract and the pregnancy diagram that we have to learn. So module 1, we have a workbook, and in the workbook there's lots of questions on chapter 11, which is diseases of the digestive tract, and chapter 15, 16, 17, 18, sorry, signs and symptoms and abnormal clinical findings. And then the OPCS, so remember OPCS is procedure coding. We have lots of questions relating to these chapters here, which all kind of tie into our endoscopy coding. Then module 2, so once they've passed that module, to pass a module, they have to complete the workbook without the answers, and it's timed, and they have to get at least 90%. So I give them the workbook at the start of the module, they study it, and then once they're confident that they can do the workbook independently without answers, then they'll sit an assessment, which is basically do the workbook. I mix up the questions a little bit, and they need at least 90% to pass that. So as well as studying this workbook, the trainee will only be coding endoscopy coding for the first module. So it'll just be nothing but endoscopy coding. And the reason for that is for them to learn everything that they'll need to know in order to code endoscopies independently. So once I've had, it's normally about a month. So once I've had a month on this module and this workbook, we will do the assessment, the workbook assessment, and also they will undergo an actual official audit. So our accredited auditor here will audit their endoscopy coding where they need to meet the required standards. So once they're signed off on module 1, we will then give them module 2, which is obstetrics pediatrics. So mums and babies. Now this is where the morning and afternoon things break up. So once they've passed one module or more than one module, once they can code something independently, in the mornings, they will be coding what they know, what they've been signed off on, and in the afternoons, they'll be coding new stuff. So if somebody's been here for 2 months, they've been signed off on endoscopy coding, and they've just started obstetric coding. In the mornings, they'll code endoscopy coding independently. Obviously, they still will be audited at certain intervals to make sure that their accuracy is high. And then in the afternoons, they'll look at the newer stuff. So that's how the training program goes at the trust that I work at. So the workbooks are really handy. In the workbooks, there are lots of theory questions, lots of practical questions, and lots of diagrams. And at the end, there's also common abbreviations for that specific specialty. Now onto the examination. So this is the examination that coders are kind of working towards. So this is the National Clinical Coding Examination. There are two parts to this. There are paper 1, which is practical. So this is basically doing coding. And then there's paper 2, which is theory, and this is the ability to recall certain theory elements of coding. So for example, one common question is, what is the primary diagnosis definition? Or what is the definition of intervention? Or can you explain the rules associated with coding such and such with such and such? So this is the ability to recall kind of theory elements. Also in the theory paper are anatomy and physiology questions, anatomy and physiology diagrams, excuse me, things like that. So as you can see, each paper is 3 hours long. So you'll be the coder will be sitting there for 6 hours, at least 6 hours, or no, maximum 6 hours. You can finish a little earlier. Just doing examinations, which is quite difficult. The practical element, we need at least 90% for a pass. That's quite a high kind of score, especially when you consider it's 3 hours long, that paper. That's a very difficult paper. And the theory, we need at least 70% to pass. Theory is you've got a little bit more leeway because for the practical, you can kind of work out things that you've not seen before, whereas the theory, they could chuck any kind of theory question at you from a bibliography. So those are the pass marks. Now we've also got distinction marks. Now a distinction is kind of every trainee's wildest dreams, I'd say. So for practical, if you got 95%, that would be a pass with distinction. If you got at least 85% for theory, that would be a distinction as well. So it's a very difficult examination, but it is achievable, especially with the training. If you've got a really good training program implemented at your trust, it is very achievable. You just need to put a lot of work in. There's a lot of work needed outside of work hours as well. You need to, a coder needs to put a lot of study time in outside of work, but it is all to kind of get this NCCQ examination under the belt. So once you've achieved at least 90% for the practical and at least 70% for theory, you will then be an accredited clinical coder. You can then put ACC at the end of your name and introduce yourself as ACC forevermore. I don't do that much. So upon passing the NCCQ, you'll get accredited clinical coder. At our trust, there is a financial incentive to passing the examination. So for us, the banding is you come in at a band 3, and then after a certain amount of time, after about a year, we will audit you and give you an assessment, like a formal test. If you pass that kind of local test, you go up to band 4. And then that would kind of be that your exam ready, your NCCQ exam ready. So then you'd be expected to sit the NCCQ examination. If you pass the examination, then that's when you get your band 5. And then there are more options after band 5. So once you're an accredited clinical coder, the learning does not stop there. There is a lot more things that we can do. So we could put you on training workshops, specialty workshops. So if, for example, you feel like maybe obstetrics is a weak point, we could deliver an obstetrics workshop, which goes into the specifics of obstetric coding. You could look at kind of local things that you see and documentation. And also, once you're an accredited clinical coder, you'll then need to do a clinical coding standards refresher course every 3 years. Now, that's kind of to make sure that the coders are still kind of up there with their knowledge of the standards. So it's not like you're an accredited clinical coder, now all of the training stops. The training very much goes on whilst you're an accredited clinical coder. At our trust, we have delivered orthopedics workshop, vascular workshop, endoscopy workshop, osteotomy of the foot workshop, and I'm sure there's more vascular. Yeah, I've already said vascular. COVID workshops, stem cell transplants, and also there's lots of training on how to use new systems whenever they are implemented at our trust. Now, once you're an accredited coder, you can do other things. So once you're an ACC for at least 3 years, you can become either an auditor or a trainer. So obviously I passed my ACC examination. After 3 years, I was like, you know what? I think I might want to do a little bit more. So I started down the training route. Personally, I don't think I'd be a very good auditor because they are very skilled. They're very, very accurate. Very, very good at giving feedback. But I like to kind of teach people from the start. Also, another thing that some trusts have are divisional leads. So at our trust, we have 4 divisional leads. So these are senior coders who are responsible for certain divisions. So we have a divisional lead in general surgery. So if any of the coders have a question about general surgery, the first person they go to is our divisional lead for general surgery. If that divisional lead doesn't know the answer, or if there's something that needs clinical input, then that divisional lead will then liaise with the clinician to get the answers. So we have divisional lead posts here as well. Now the trainer, auditor and divisional lead posts are all band 4 at this trust. I must say banding varies from trust to trust. So here at ESNEFT, a qualified coder, an ACC, will be a band 5, but that's not the same for all trusts. So I spoke about auditing earlier. So these are the standards that the trusts need to meet for our DS&P audit. So this is our data security and protection audit. So this is what we have to submit every year. So every year our auditors across Ipswich and Colchester create a structured audit plan for the department to ensure everybody is coding as accurately as they need to, as well as kind of making sure any new standards or any new rules that have come in are adhered to as well. So this slide shows the national requirements. So this is a national thing that each of the trusts need to kind of meet. So for a primary diagnosis, secondary diagnosis, primary procedure, secondary procedure, we've got a standards met row here. So primary diagnosis, at least 90% for standards met. Secondary, at least 80%. Primary procedure, at least 90%. Secondary procedure, at least 80%. Now, the reason the secondary diagnosis field and secondary procedure field is a little bit lower, we've got a little bit more leeway, is because the majority of the time you will have more secondary diagnosis than, obviously we've only got one primary diagnosis that we can assign, but we could have 10, 15 secondary diagnosis on some of the more complex cases. Now, if a trust is brilliant and the coders are mega, then they could potentially meet the standards exceeded row. So as you can see here, we've got the percentages there for a trust who has exceeded the standards. Those are very, very high scores. Our trust is very close. I think we got standards exceeded for 3 of those at our last audit, which is I'm really proud of the work that we're doing here. Did I see a question? I'm happy to.
Sorry, you answered it as you was.
Oh, okay.
Thank you.
Excellent. So this is the workload at the trust that I work at, ESNEFT, for the past 3 months. So I just want to give you an idea of how many episodes our coding team or a coding team would need to code. We have a team of 37 coders. Now, among those numbers, we have 6 trainees who are currently going through the training program. We've got 2 auditors, 4 divisional leads, 4 contract coders, 1 trainer, and a partridge in a pear tree. We don't have a partridge in a pear tree. I just thought I'd throw that in there. So that's the team that we've got. Now, over the past 3 months here, you can see the kind of numbers that 37 coders would need to code within a month. Now, an episode is, so if a patient comes into hospital and is seen by 3 consultants, all looking at different things, there could be more than 1 episode within that 1 hospital stay. So an example is if a patient comes in for an appendectomy, or they've got appendicitis and they just so happen to have a stroke or something whilst they're in hospital, then that the care would then be moved to a stroke consultant. So that patient would have 2 episodes in that hospital stay. The first episode would be for the appendicitis, second episode would be for the stroke. That's a really extreme case that I just thought of there, but we code each individual episode like uniquely according to what happened within that episode. So within June, we coded 17,727, July 22,269, and then in August 17,068. These are quite high numbers, so I'd say it's been a cruel summer, but these are the numbers that we're coding at the moment. Now, I mentioned that we've got 4 contract coders. Quite often, I think is very common amongst hospitals. We're not fully staffed at this trust, so we try to kind of keep on top of our workload using contract coders. At this trust, before we consider taking on a contract coder, they have to sit a local kind of assessment to make sure that their coding is up to scratch, because for us it's really, really important that accuracy is key. So we make sure that if we take on a contract coder, it's not going to make our figures or our accuracy kind of go down, because we want to make sure that's up there. So those are the kind of numbers that we're looking at. Now, I've kind of come to the end of our of this presentation, so I've got a blank space here for questions. Does anybody have any questions for me? Melvin.
Hello, good morning, everyone. My name is Melvin, and I am a clinical audit nurse at King's College Hospital. So I work for the critical care department, and a part of our role is, I guess, similar to what clinical coders do, in the sense that we read through notes, and then we also code patients for the reason that they come in the ICU, although we follow a different kind of standard. We use the ICNARC coding method. I'm not sure if everyone's familiar with that, but it's a national audit program for patients' outcomes within their ICU stay. And also we also collect data for ICU commissioning as well, which is the critical care minimum data set.
Yeah.
I was just curious, I guess, with how ICU data, and I guess the data that we collect is linked to the workflow of clinical coders further down the line of a patient stay, after they have been discharged from the ICU, and then they continue their stay on the ward until they eventually get discharged. So I was just curious about how you look at ICU, a patient's ICU stay kind of notes.
Yeah, so that's a really interesting question, actually, because I'm not 100% sure what happens to the data that you submit. At what point during the patient's kind of episode do you submit those codes? Sorry, Melvin. Is it like straight after their admission, or is it whilst they're still admitted? I suppose if it's outcomes, it'll be afterwards, wouldn't it?
Yeah, so we tend to kind of start the collecting data within 24 to 48 hours of the stay, just to, because a lot of the information are available there already. Like, for example, the reason for the reason for them getting admitted to the ICU, their 24-hour physiology, and then kind of follow it up to complete, the rest of the data set when they eventually get discharged from ICU and then out of the hospital. And then when they get transferred to a different hospital, we sort of follow that up as well to kind of complete the whole acute hospital stay.
Oh, okay. I mean, I can share what a clinical coder does with the ICU or CCU episodes. We code it as we would any other episode. I think maybe you probably submit more kind of granular data than we do, because certain elements of the hospital stay are not coded because they're considered to be a routine part of care. So, for example, if a patient has come in and a catheter has been placed just for sort of urine monitoring, we won't be assigning a code for that catheter. We would be assigning a code for the catheter if it's outside of the routine care. So if a patient went into retention and a catheter was inserted for that, then we'd code the insertion of that and any kind of management after that. But if a patient is admitted and the routine part of care is to insert a catheter, then these little tiny things are not always coded. But yeah, I don't think that answers your question, because I'm not 100% sure where the data that coders kind of enter runs alongside the data that you kind of submit. It might be worth speaking to your informatics team, see what happens with the data after that.
Sure. And if I can just ask another scenario, like, for example, because sometimes you get patients that get transferred directly from an ICU to our ICU, and then that patient from another hospital, ICU from another hospital, gets admitted to our ICU, and then sometimes some patients don't survive their ICU stay. So would you still kind of code those patients even if they were in just the ICU during their entire stay?
Yeah. So that's something that we do at this trust. If a patient is admitted into an ICU and there is an inpatient episode generated for that, we would code that. That's definitely something that needs coding. Would code the diagnosis of any sort of procedures that has been performed on that patient. Yep, we code it all.
Thank you very much. Thank you very much.
No problem at all. Nigel, do you have a question?
Yeah, just a quickie, and I don't know whether you can help. Obviously, productivity is quite key across the NHS at the moment, trying to get it back to pre-COVID or whatever levels. How much does the clinical coding kind of drive that? Because, I mean, obviously, if you clinically code something wrong, I guess both your costs and your income are too high, low, whatever you want to describe it as. I'm just interested to see what the impact of kind of clinical coding on that exercise is. That may not be a question you can answer, but I'm just really interested, because I'm more looking at the productivity side. I'm just interested to see how clinical coding or inaccurate clinical coding, going back to your example of the doctor with the dyslexic scroll, how that would actually impact it.
I mean, for us, we kind of just do the job as normal. You might find that the clinicians are more rushed, and it'll be more challenging to understand what the diagnosis is. But for a coder, we'd still do the job. We've certainly felt. I showed the figures there of the last 3 months, and they are a lot higher than this time last year. So we are feeling the strain, as in our workload is becoming higher, and it is becoming a lot more challenging to hit our submission deadlines as well, because we have our deadlines to submit our data. But in terms of we're still doing our thing. I don't know if that answers your question, Nigel.
Kind of. No, that's fine. You've kind of answered it. I think I probably answered it in my question anyway. I'm guessing if it's wrong, the productivity Yeah, okay.
Yeah.
I think
Yeah,
I kind of answered it.
Yeah, no, our accuracy is key. So
Yes.
we do have a certain coded figured like individual coding targets that we set for people. We set our trainees, we need at least 30 each day from them, and our senior coders, depending on what they're coding during that day, there are a certain kind of amount of numbers output that we're expecting. But the thing that trumps all of that is accuracy, because we want to make sure our accuracy is up there.
Okay, thank you.
Thank you, Nigel. Nikki.
Hi, thank you. Yeah, so Nikki Jones from University Hospitals Dorset. Thank you very
Hello.
much, James, for the presentation.
Thank you.
If you were to give us one or maybe your top 3 things to take away from this that you would like us to share that would make your job easier, what would they be?
That is a really good question. I would say, I mean, I'll speak from kind of our trust's point of view, because one of the things that we're struggling with here is the unavailability of notes. So quite often notes either go missing or they're not delivered to us in a timely manner, or because we code from scanned documentation. So I think my message is more to our scanning team, if anything. But there's that, and also I would say try to push the clinicians to be as specific as possible. Abbreviations kill us sometimes, because especially if there is an abbreviation we've never seen before. There's so many of those coming in at the moment. So I would say if you could push anything to your clinicians to try and avoid the use of abbreviations. It's always good for the clinicians to know that I went through the terms that we can and can't code. It'd be good for the clinicians to know those as well, so that they're aware if they write a little question mark, which clinicians love that question mark, it won't be coded as that diagnosis. So yeah, I'd say try and get documentation available for the coders as swiftly as possible. Specificity is key, especially as I've spent the last 6 months trying to pronounce it, and also the terms that we can and can't use, I'd say.
Thank you.
Thank you. Rachel.
Hi again. So my question is more kind of about, I think you've touched on it briefly, saying that you've got quite a good relationships with your consultants, so you're able to maybe lead them in the right direction to writing what you need to get. I'm kind of within the service that our coding is done by our reception team, who also manage the outcomes. So they do it as part of that role within that area. And we're I think kind of a bit struggling to get our consultants to really maybe put down the outcoming codes that we really need, or be a bit more clearer with that. How would you kind of recommend leading those conversations? Because it's kind of hitting a bit of a barrier, and obviously it's impacting our funding at this point, or our pay that we get for the appointments.
Absolutely. Is it outpatient kind of appointments?
Yeah, outpatient and surgery. Yeah.
So luckily, well, our clinical coders don't code outpatients, but we do help with the production of outcome forms, which is what you were talking about. Now, one thing that you could do is to say to your clinicians, oh, there are new codes available, because there's always new codes available each April, or most Aprils. There's another update coming this April. It's going to be a big update for procedures. So you could always say, just to make sure that our codes are accurate, or our codes are up to date, can we have a little meeting to talk about this? And whilst you're in the meeting, you can sort of stress the importance of complete coding, because it is very important for outpatients as well as inpatients.
Yeah, definitely.
And that is always something that I'm wary of at our trust as well, because I'm 100% certain that our outpatient codes are not always there. And as I said, I don't think all departments know that new codes come in each April as well.
No.
So is that something you're aware of? Did you know?
No, I wasn't aware of that. We've moved from to a completely paperless system now, so all of our outcomes and coding is all online through the outcoming forms. So we use drop-down system which they tick to select the clinical codes. But I think the barrier is, well, one is that I need to streamline those codings because they're not right. And if you're saying they change every year, that might have to be an ongoing project for myself then.
Yeah, absolutely. What I'd recommend with the change of codes or the introduction of new codes on the NHS classifications website called Dellen, they release a summary of coding changes as well as a document which is pretty much all of the changes. So you could look at that document and see what has changed in terms of what's been added to the classifications. I'm interested to know, do you code diagnosis and procedures?
Yeah, we code everything.
Okay.
Yeah, we code everything. Thank you.
No problem at all. Don't know if there's any more questions in the chat. Do clinicians receive training on how to take notes to help clinical coders correct at source approach? I deliver a presentation or a session to doctors' induction events. So I've just done a couple of doctors' inductions, I think it was last month. As well as that, at our trust, there is a bit on our intranet where I've recorded a video for clinicians to look at. In addition to that, I think it all depends on how kind of your coding team interacts with the clinicians, basically. I make sure that I'm at most clinical meetings to get that kind of get our word in. But yeah, that's basically depends on what your trust is like. Don't think they receive formal training. I don't think it's like a NHS England kind of formal training that they do. But it all depends on how proactive your coding department is to get that message across. I think most coders or most coding teams share the same problems. So I'd imagine they're quite good at talking to clinicians. Are there any other questions? I do want to. Oh, another question. If you didn't reach the pass rate the first time round the NCCQ exams, do you have an opportunity to reset? Yes. If you passed one of the papers, so if, for example, you passed the practical paper, but you failed the theory paper, you have 3 more attempts at coding, at passing just the theory. If you failed the theory 3 times after that, then you'd have to sit both papers again. Each trust, so our trust, we pay because it's quite an expensive examination. So, and as an extra kind of push to make sure our trainees study, we pay for the first 2 attempts. But if there's any more attempts, then the trainee has to pay for it themselves. And it has kind of given our trainees a kind of good push, because in the past we've had years ago we had coders who they didn't really put much effort into studying, and they kept failing, and it was quite a lot for our trust to pay out. So in the end we said, right, we'll pay for 2 of them, and then any others you have to pay for yourself. So you can resit, and I think it depends on which trust that you're at, whether you pay for it yourself or the trust pays for it. So Nicole, I am currently part of a massive outpatient coding review at our trust. I sent a blanket email to clinical leads and operational management and asked what exactly is carried out in their clinics, and cross-referenced that with our department outpatient coding data to identify the gaps. It's painstaking, but we're uncovering lots of things in the outpatient coding process that needs attention, both human and in system. You're doing some really good work there. I don't think trusts are as proactive in looking into their outpatient coding as they perhaps should be. Obviously, the people who do the outpatient coding are not qualified coders, so there's going to be a lot of data that they don't enter. For example, a clinical coder will assign a code for a procedure, and if that procedure title doesn't have the site or laterality of where the procedure has been performed, we would add codes to it. So, for example, if something happened on my right arm, I pointed to my left arm there. That was embarrassing. If something happened to my right arm, I'd assign a code for right-sided operations. And I suspect there's so many of these little things that are not coded in outpatients. So that sounds like you're doing some really good work there, Nicole. Any other questions? I've got one question though. I've got one question for you all. I've kind of thrown in a secret theme to my presentation, not necessarily anything that you've seen, but some things that I've said. Did anybody catch what the secret theme is? I think I slipped the theme in very discreetly, so you may not have picked up on it. Anybody catch a secret theme? Popular at the moment.
I have no idea.
No. This is just something that, do you know what? I thought I'd slip this in this morning, so I kind of thought of it this morning, just from. So during my presentation, I actually said the title of 12 Taylor Swift songs. Random, I know. But
That's quite good.
I thought someone might have picked up on it when I said "Shake It Off," and what did I say at the end there? I said "Cruel Summer." It's been a cruel summer for us. So yeah, I slipped in. There's 12 Taylor Swift songs in there. So if you feel like you want to listen to it all again.
I remember the Partridge in a Pear Tree though.
Oh yeah, well that's not a Taylor Swift song. That was even more improv. Okay. So thank you very much for listening and all of your interaction. It's been really good. Thank you very much.
Thanks.
Thanks.